Okay, once again, Olarinwaju Lawal, not Olarinwaju, that will be a different person. So, it's called speed, so I'm going to go at incredibly fast speed. So I hope you can keep up with me. So this is the pilot project with titled Patterns and Association between Social Vulnerability Index and HVI and COVID-19 epidemics. The idea around that is to look at social vulnerability. It's moving here, not there. Oh, okay. To look at social vulnerability and try and see how we can leverage that, because we know from existing literature that social vulnerability can help to, we know vulnerable places usually have very negative outcomes in terms of disaster or hazard or even health outcomes when things go bad. So knowing that, the other part of it is that in Africa, in sub-Saharan Africa, the data that is available is often at a regional scale or at the national scale. And that's not good enough for making decision at a highly granular level when you need to address issues. So for these pilot projects, the first aim is to develop and share the SVIs, identify patterns and association between the SVI, HIV, and COVID pandemics, and to build capacity of researchers and public health officials to use what we have developed. So, aim one, the idea around that is to source for the data, create a platform whereby we create a pipeline where data is ingested, analysis is carried out, and then the SVI is actually computed. Once the SVI is developed, is computed, then the next thing is to analyze. We plan to use geographically weighted regression and bivariate spatial association to understand the association between HVI and COVID-19 epidemic across the countries that we have developed the SVI for. And finally, to develop capacity of people to use it. So that's also another way of trying to share what we have developed and ensure that people can take it up and use it so that we are not wasting effort. So far so good. We have completed the first aim. We have developed for those places we have been able to secure the data, the publicly available data, the FAIR data. We have been able to develop that. And whenever I look at this map, I think it's something that is interesting to look at. Some initial thoughts around that is that moderate to very high are the most common classification that we have found, and I have a little bit of the statistics up there. And we hope that as we begin the next phase, trying to train people to be able to use it, then we can get feedback and know what we might need to do better and how do we take this on going forward. Because this is a snapshot using data that is available from recent fears. So hopefully we can create a pipeline. That would be the next thing we want to do, to create a pipeline where data is ingested and the analysis is done in a seamless way. So we have initiated the collection of HIV and COVID-19 data to the same level, to the third administrative level for each of the country. We have initiated that. This has been mentioned before to disseminate. We are already on that. So January, February, March, there will be training to facilitate the usage and support and to support decision making for the stakeholders that are likely to use this data. There are papers in the pipeline. We hope that by January 2025, the first paper is supposed to go out. We already submitted an abstract for a conference presentation. We are waiting a decision on that. And the paper on analyzing the pattern and association, we know that the draft and final paper should be ready, touch wood, by March 2025. And the integration has already started. And we are hoping to put on the Refill platform and also use other sites and other platforms to also disseminate the data. So because at times people want to just download the data and do their own analysis. So that's what we have in the pipeline, and I want to thank a whole lot of people for making this a reality. Thank you very much.
Good afternoon, everyone. My name is Kenneth, and I lead the vaccine coverage mapping project of Inform Africa alongside my colleague Victoria. So I'm just going to take us briefly through what we've been able to do in the past 1 year. Am I supposed to control it from here?
Yes.
Okay. How? Oh, okay. Okay, so we'll just go through this outline. We'll look at the project objectives, the methodology, data sources, results, next steps, and acknowledgement. So these are just abbreviations of some of the things we used in the paper. Okay, so our objectives were broadly divided into two. We wanted to determine the impact of COVID-19 vaccination coverage on geographical disease prevalence in Nigeria, and also to identify factors associated with vaccine coverage variations across regions in Nigeria. We developed, the methodology was development of a vaccine coverage mapping dashboard that would triangulate COVID-19 vaccine coverage data and also COVID-19 surveillance data at the state levels in Nigeria. Additionally, we wanted to do a geospatial and statistical analysis to identify associations between COVID-19 vaccination coverage and the disease prevalence also at the state level. We got data from 4 different sources. One of them was the electronic management of immunization data, where we got the COVID-19 vaccinations data that was being managed by the National Primary Healthcare Development Agency. We also got data, surveillance data of COVID-19 disease from a platform called SOMAS, which is being managed by the Nigerian Center for Disease Control and Prevention. We also got some data from the Nigerian Population Commission, which is 2019 estimated data from 2006 population census. And finally, we got COVID-19 vaccine eligible population data, which is an aggregated number of adults aged 18 years and above at state levels in Nigeria. So a accumulation of this 4 data gave us a more robust available data to be able to triangulate the data that we needed. Okay, so this is the result. So currently we have been able to develop a dashboard which is ready to be used. This dashboard summarily contains 13 maps, graphs, and charts, which were divided into 3 modules. Module 1 had vaccine coverage across regions in the country and also at the state level. Module 2 had the surveillance data for COVID-19 disease, also at regional and state levels. And then module 3 was an integration of both vaccine and the disease data at both regional and state levels. So, so this is one of the diagrams that was on the triangulation part of the dashboard that shows the COVID-19 disease data. On it is superimposed the vaccination data. Interestingly, we found a special correlation between COVID-19 vaccination coverage and the states, which showed a statistical significance. And also we found an inverse association between COVID-19 vaccination coverage and the disease prevalence. So what are our next steps? The plan is to deploy this dashboard for use by those that make decisions in the country, and also leverage on the use of machine learning tools to do some further analysis, and also to widely disseminate our findings through manuscripts and conference presentations. I just want to thank my boss, Professor Lashley, for this great opportunity, and also Sophia and my co-lead, Victoria, and everyone that has contributed to the success of this work. Thank you very much.
Hi, everybody. My name is Kennedy Otwombe, as I have mentioned before, and our Inform Africa project was to look at pandemic preparedness. And today I'll just present a brief set of results from what we've put together, and I'll give you a bit of history of what our experiences have been. I've got a couple of other co-authors, and once the draft paper is done, I'll circulate and everyone can comment on, and let's work together and write the paper as joint collaborators. I love collaborating. So we all remember the impact of COVID, and there's a lot of havoc. Some of the key challenges we saw that clearly impacted our preparedness was things to do with resource allocation. We struggled with that, especially in our continent. We had challenges touching on surveillance. We struggled with that in Africa, and in this particular presentation today, our aim is to show how some of the indicators we are working with are associated with reporting of COVID-19 cases. I want to be clear that I'm not looking at predictors of COVID. I'm looking at predictors of the reporting of COVID cases and COVID deaths. I must be clear on that because I had a presentation with Kenneth, who was very clear on how I should send this messaging. Thank you, Kenneth. At least it's good we're staying within the same hotel. So, those problems included procurement of the vaccinations, communication, a lot of misinformation. Then we had a lot of problems with lockdowns, which had a ripple effect in so many ways. So our interest today is to demonstrate how various indicators influence the reporting of COVID-19 cases and deaths. But more importantly, we also want to build on the work of Inform Africa, which is centered on the development of population scale data streams, building on Inform Africa's efforts to establish a cornerstone for future pandemic preparedness. And with that, we put data together cross-sectionally, and that data was sourced for only the African continent. We initially started looking at literature from what we call the Carter Evidence website. The link is there, https research nexus. And then from there, we identified a number of relevant indicators from the WHO website, the World Bank website, and the World Ometer for coronavirus statistics data. You'd remember the Johns Hopkins open data that was being populated regularly when countries were updating their numbers. That has since stopped. A couple of indicators of interest are centered on the EPI parameters, health, workforce health system, WASH, which touches on sanitation and hygiene, health financing, and financial indicators. So in what I'm going to talk about today, will be focused on modeling total COVID-19 cases per million and total COVID-19 deaths per million. I'm also going to show a table showing just the COVID cases modeled on their own and deaths modeled on their own. So I have quite a bit of data. I've got about 4 or 5 regression models, but I'll just give a quick overview of what we found. So we did see, I'm going to skip this for now. We did look at 54 countries with those data. Those are about 12.8 million cases that were reported from Africa, with about 259 deaths. And there was 10 million COVID-19 tests conducted. Majority of those were in Southern Africa, followed by West Africa. Now, more importantly, we have found that countries that invested in sanitation, water and sanitation, were more likely to report lower COVID-19 cases and COVID-19 deaths. countries that reported on current health expenditure that was high and high hospital deaths per 10,000 people were more likely to pick more COVID-19 cases and also report more COVID-19 deaths. And then when we modeled just cases, so the first regression model looks at COVID-19 cases per million. So it's a rate, and deaths per million. And the second model we looked at was we just modeled the number as given for cases and for deaths. We must also recall that one of the limitations of the data sets that we have here is that the numbers that were given may have been repeat cases of people that had cases. So we have no control of that because it's population level data. And so with that, we can comfortably say, again, based on the data that we have, is that countries that invested in that resource of pharmacists were more likely to pick COVID-19 cases and COVID-19 deaths, and they were more likely to, countries that had a total density per 100,000 population of district and rural hospitals that was more, were also likely to pick more cases, report more cases of COVID and more cases of deaths. So looking at where each of those parameters lie, we at least for now can say that investment in water and sanitation, health workforce, health financing, and health system strengthening in future would be an important area to look at in order to prevent any future pandemic. I'd like to thank Inform Africa for the invite to this conference, and a couple of other sponsors, including the University of Witwatersrand, APHRC, Qatar, and my employers, PHRU. Thank you.
I made a poster, but actually it's gonna help me to don't spend time with the transitions. So today, today I'm gonna present the results of our first paper from the pilot project. As Cheryl mentioned, we are working 3 papers for the pilot. This was submitted this week. We have another 2 that are ongoing and will be submitted soon. So this one, the pilot project focused on producing machine learning models to classify viral lineages. So the reason that we are doing that is we all know that the next generation sequence technologies are producing trillions bases per run. And this is more than what alignment-based techniques can afford, can work on it. So in this been like we don't have computational power enough for the alignment-based techniques are time-consuming. So we are addressing machine learning techniques to try to classify a viral sequence in a more fast way and speed the process of prepare for the next pandemics. So our model, our methodology takes in consideration the sequence. We use feature extraction techniques to extract features from this sequence. We transform these features in numerical vectors, and then we apply a machine learning model to classify the sequence into the class that are in place. So we tested many algorithms for the classification. In the end, we used random forest that performed better. For the feature extraction methods, we tested K-mass, spatial word frequencies, MASH, genomic, I can't say here, genomic signal processing, return tree distribution, and the frequency Gauss game representation. This last one actually is the one that we are getting better results. So we apply this methodology in 3 different data sets, different size. So dengue with over 7,000 sequences and 131 lineages, which means 131 classes for this model to classify, which is already a lot. So the HIV one with over 4,000 sequences, and the SARS-CoV-2 is the larger one with over 290,000 sequences and over 3,500 lineages, which is very challenging for a machine learning model. So as a result, we saw that the model is performing very well. I included here the results for dengue and SARS-CoV-2, which we got the best results. So overall, we got 98% of accuracy. So, and for the HIV, 89% of accuracy. These graphs we are representing here all the lineages that were classified. The evolutionary depth is represented by the length of each bar, the clades by the colors, and the lines inside are the accuracy we got it. So to understand, you can see these ones that are like sharper are our worst results. So we analyzed here these results. Let me scroll here. Oops. Sorry. Yeah. Where is the IT? Okay. Now here. Yes. Sorry, but this was important. This Sankey graph shows our worst results, how it performs for the classification. This side, we have the targets, so with the original class. So this other side, we have the class that were predicted for the model. Even in the worst case, so we can see that we could classify until certain level of the hierarchy correctly in all the cases. So in the most of the case, we are missing the last level of the hierarchy, which was my first hypothesis, that we should work on the hierarchy until we can have a certain amount of sure that we are classifying correctly, and then working the ones that are unsure, and we can involve humans, specialists in the process. This is the next step of the project. So we are already addressing the hierarchy in the next paper, and also the anomaly detection and the active learning in the third paper. So as a result, we compare our model, our methodology, with the state of art for viral genomes classification, which is Genome Detective. The ideal scenario for Genome Detective is they are alignment-based methods, just to highlight. So they ideally classify one sequence per minute. So from our experiments, we found out that they are classifying 0.17 sequence per minute. Our method is classifying over 10,000 sequence per minute. Thank you.
All right, 5 minutes, right? Okay. Okay, I'll try to do it quickly. So basically, yeah, I got the same message. We also prepared a poster. But yeah, I'm sure you're all tired of presentations. Posters are it's changing format. Okay. So very short, our project is trying to do the translate work, basically. Translation of engineering language into something that people in this room and also who are really using the data can understand. First of all, let me ask you this. So we have presented our next year's goal a few minutes ago from a Project 2 perspective by Dr. Xing. How many of you think you really understand what we're trying to do?
As long as it's more than
Okay. All right, so let me translate that a little bit for him.
You're doing what you said you would do in the specific area.
Yeah, it's only 3 words. Trust our work. So basically, we're trying to deliver our data to you, okay? And trust us, we're the best transmission data that you can get. We're the only winning team to provide data to US DOT of the comprehensive daily travel itinerary data on a daily basis. They're demonstrating this as phase 1, phase 2, and now we're doing the mass production for Utah states, demonstrating this whole idea. So basically, we're pouring in our latest research findings from transmission perspective into this project, okay? Then from this pilot project, we're testing our idea how we can really translate this data set to all the potential data users or data users now who can benefit from this data set, what a travel data look like, what it is, right? So our analysis focuses on trips. People are making one-way travel from point origin to point destination. That's called the trip. Then we analyze daily trip chain. We're linking your trips from, say, 8 a.m. till, say, 8 p.m. when you arrive home. We analyze your home to work to lunch to some other places to your work. Then after work, you pick up your kids and go back home. We form this whole trip chain for you, and for everybody else that's observed in our data set. Then eventually we expand our sample to cover the entire population, okay? So that means we're doing this microscopic, individual level travel analysis for every single individual in a country of our study interest. Then we can make this level to the next aggregation, mesoscopy levels, that is within a city, within a province. We can also do macroscopic, national level, international level. You name it, we can deliver that data to you as the transmission data set. Okay, so that's the whole idea of a project 2. We want to do that model at the individual level. We call it agent-based model. Okay, then the only one who understands my language, Megan, we're making this agent-based simulation into a simulation not only about mobility, but also linking the disease transmissions into it, forming an agent-based mobility-epi model as our final aim of project 2. Okay. Hopefully that model can also not only serve our purpose of understanding the past pandemic, but also some of the emerging issues of flu, mpox, and other things. So that's our overarching goal, how we can link our M3 also even further into the next 5 years. Good. So we tried our best by traveling ourselves to Nigeria, testing our idea. We have worked on a 1-week workshop with a lot of our trainees. Many of them were even sitting here in this room, and we were collecting useful feedback. So basically, we tried to analyze. There's a pointer. Fantastic. So we try to analyze our mobility data. This shows us mobility decrease, increase over time. We also transferred our other knowledge about climate change. In a nutshell, these ones are periodically sensed satellite images about the water levels using Lagos as one example. And then we sensed the entire nation of Nigeria at different time periods, measuring the size of the flood compared with the state and the local level areas of geography to form understanding of how severe the flooding is. Then we can also link the data set to other informations, including point of interest, that's the grocery, medical, so on and so forth. So we can pinpoint before flooding, during flooding, after flooding, what's the mobility decrease, increase, and decrease dynamics. Overall, I think we have collected enough information for us to go back, revamp of our 1 week of training, and think about different ways to further engage our DSI Africa community. We could offer a pre-workshop at the next annual meeting. We can do it online. We can do it another time at a preferred location. So that's what I'm requesting the NCE for, no cost extension for. So hopefully we can bring up more ideas today at the discussion breakout rooms to think about, how we can do more translational work and for just to pinpoint the key for the next 5 years, including how we can disseminate our knowledge and also generate more capacity building and do more together. That's it for my 5 minutes. Thank you very much.